So I'm really delighted to introduce Dr. Karen Jacobson, who works at the intersection of inclusion health and global health, an area that we're very much interested here in at UCLTB. And she's going to give us a talk about her work on studying substance use in tuberculosis transmission and outcomes in South Africa. Just to tell you a bit about Karen, she's an associate professor at the Boston University Schools of Medicine and Public Health, and she's also medical director at the Boston Medical Center Tuberculosis Clinic. Her research focuses on the epidemiology of tuberculosis with a particular emphasis in understanding how substance use impacts on TB transmission and response to therapy. And she's developed quite a close collaboration with researchers in Cape Town and South Africa over the last 13 years. And she's going to be telling us about her work in this area. So over to you, Karen. Really looking forward to your talk.
Wonderful. Thank you, Hanif. Thank you for that nice introduction. And I'm excited to speak with you all today and leave enough time that we can hopefully have a bit of a discussion at the end. So again, my goal today is to tell you about the work that we're doing, studying substance use and TB transmission and outcomes. I have no conflicts to report. I do want to say before I get started that, again, as Hanif outlined, I am an infectious disease doctor by training. That's really the perspective that I bring to this, and that all the rich information on substance use I've learned, but also really is led by my collaborators, who I will tell you more about today. So I think everyone on this call knows that the World Health Organization really came out with these very aggressive goals to decrease tuberculosis globally by 2035. But that although ideally we would get down to 95% reduction in deaths, incidence rate, and really take away catastrophic costs, that the projections have been that we really will need some major innovations and able to get there. That if we continue along the path that just optimizing our current drugs and tools, that will only get us so far, but that really we need better regimens, shorter regimens, better diagnostics, and better vaccines. And so seeing hopefully where innovation and funding will go to get us these new tools is a super exciting aspect of this field. But I think we also need to remember who we're taking care of and who we're trying to reach. And so for many of these new innovative studies, it is often of concern about who do we include when it comes to clinical research, clinical trials. And I'm putting up this exclusion criteria because it's one that I think is pretty standard in a number of the sort of higher investment protocols. And I want to highlight in it this idea that we might exclude people who with substance abuse problems that, in the opinion of the investigator, will make it unlikely that the participant will comply with the protocol. Our concern is that by excluding individuals who are using substances, you are going to lack that ability to generalize to them, but also to engage them in care and engage them in treatment. And I think while new tool development is critical, really if we're going to get on top of TB, we need to do that in tandem with making sure that we're reaching the most marginalized groups and making sure we're understanding how does substance use potentially be very important modifiers when it comes to TB transmission and outcomes. So I got interested in this now, gosh, I guess it was almost 10 years ago. The World Health, different groups had really started to come out with what are major risk factors for tuberculosis. And although we know on an individual level that people with HIV have this highest risk of progression to active disease, that it really modifies the host on the individual level the greatest amount, that after that, there's 5 other big modifiers, including malnutrition, diabetes, heavier alcohol use, meaning more than 40 grams a day, smoking, and indoor air pollution. And these really increase the risk of active TB probably around 2 to 3-fold. And on an individual level, again, this is much lower than HIV because these other comorbidities and cofactors are so prevalent in many communities. On a population level, this actually ends up being a bigger population attributable fraction, and that really, if we can address these other cofactors, we will actually have a major impact potentially on TB for the population. That said, alcohol had really stood out, at least until recently, as something that people found more challenging to study and didn't necessarily think of as one to really capture to better understand alcohol and its progression. So we've thought about it, and one thing that we argue is that alcohol probably acts on many steps of the cascade, that it probably modifies people's risk of actually getting infected with TB, that it actually does seem to potentially be associated with progression to active TB, and that we and others have shown that it looks like it also modifies treatment response. So as again, Hanif mentioned, I've had the opportunity to be working in South Africa in the Western Cape province since 2009. I've been working primarily in Worcester, which is a rural town, sort of the largest city in the Winelands region, 90 minutes drive outside of Cape Town. And you can see on the right, this community has very high rates of tuberculosis. It's estimated around 1,000 per 100,000 cases, incident cases per year. And this may actually be an underestimate, and we can discuss that a little bit later. It also has very high alcohol rates, and that really stood out when I started working there to understand isoniazid monoresistant TB. The region has I mentioned, has wine farms, and has unfortunately the legacy of the DOP system, where workers who lived on those farms were often paid in alcohol, at least in part. And it really meant that there's a culture of drinking within families, within the community, leading to very high rates that persist to today of just really heavy alcohol use. And what's also, I guess, interesting is that women also drink. So there's an opportunity to look at gender effects as well. So I've been working with Rob Warren at Stellenbosch University, and then other collaborators at University of Cape Town, where we've been really trying to start to work in this community and understand some of these effects. Some preliminary work that we did, this is with two members of my team who've now moved on, Lizzie Reagan and Mary Kleinman, and others. We did a meta-analysis to see how does alcohol associate with poor treatment outcomes. And what we found in the table on the left is that global studies found that if persons were using alcohol, that it seemed to increase the rate of poor outcomes about twofold. And we stratified on drug susceptible TB and multi-drug resistant TB, and we found a similar effect in both groups. And this was poor outcomes in that left table is defined as treatment failure, death, or loss to follow-up. But then one question for us was, if you remove loss to follow-up, which may have a greater association with a behavioral pathway, do we continue to see the impact on just treatment failure and death? And that's what we see in the right column, is that it does persist, that individuals with alcohol use still had a twofold increased risk of just treatment outcomes and death compared to those who not. And it really raises these questions about what is driving these poor outcomes. One other thing that we found in this meta-analysis, though, is that alcohol is not as regularly captured in a standardized fashion in TB studies, and that it's something to continue to strive for or consider when people are doing these complex and interesting work. So we sort of came up with this framework as we continue to think about it, is that what is the relationship between heavy and harmful drinking and both increased progression to disease and poor treatment outcomes? And I think a lot of the field has really focused on the behavioral mechanisms that alcohol may interfere with the ability to engage in care, initiate treatment, remain on treatment, potentially also prioritizing or substituting nutrition with alcohol. But that if we can look at that, address that, do we continue to see any biologic effect of the alcohol as well? Whether alcohol impacts on TB drug metabolism, the impact on end organ damage, and also even on the individual effect on lung macrophage function. So we had the good fortune in 2015 to get funding from the National Institutes of Health in the US. Initially a first study, and now there's a second add-on study to look at tuberculosis treatment outcomes and alcohol use. So what have we been doing in this study? The first aim has been to look at if there's a capturable association between problem alcohol use and TB treatment response, and then to see whether these associations persist independent of adherence to TB treatment among people with and without HIV. The second thing that we did was to look at the effects of problem alcohol use on the pharmacokinetics and pharmacodynamics of TB drugs among people, among those just without HIV. And the reason that we focused on that was that we were concerned that if we included HIV, the HIV effect would just overwhelm the alcohol effect on the TB metabolism. So we thought to start with just TB and 8 people without HIV. So sorry, this is a bit of a busy slide, but what you can see here is this is the flow diagram and our engagement with our participants, who we appreciate for their sticking with us in this study. So the study is a longitudinal prospective study. We aimed to enroll 300 individuals. We estimated this would be about 100 with HIV and 100 without. We do a pretty intense baseline visit. This is, we enroll people within 3 days of their initiating TB treatment for drug-susceptible TB. We do biobehavioral interviews. We get blood for alcohol biomarker, other baseline liver function, CBC. We have been collecting PAX gene tubes and more recently COVID serologies to be able to adjust in our models. We get a chest x-ray, we get a TB isolate, and we get medical information. And then our participants have agreed to have DOTS workers come to their home 5 days a week to confirm that they're taking their medications, so that we can capture a level of adherence. And I'll get into that in a moment. Participants then also give weekly sputum samples out to 12 weeks, and this is our primary outcome that, again, I will get to in a moment around sterilization. They come back then for an in-person monthly visit, which is timed when they would be coming to the clinic, and then we followed them after treatment every 3 months for a year. In a subset, we invite to participate in the PKPD. This is 100 individuals without HIV, and they come for a 1-day intensive PK sampling. This was developed by Helen McKilleran at University of Cape Town, and Paolo Denti is leading the analysis now. And this is done somewhere between 4 to 8 weeks of being on treatment so that we get to steady state. So what are some of the things that we're doing? So one of the challenges in alcohol research is, how do you capture alcohol? And so what we're doing is we're doing it on multiple levels. We use the audit, which is a pretty standardized alcohol self-reported measure that reflects usually the past year of alcohol use, as well as sort of the impact on daily life. And then we also captured a serial measure, which we did the timeline follow back. So this is our staff sits with our participant and says, okay, over the last 2 weeks, let's go into detail about what you drank, how much you drank every day, so that we can start to approximate an actual quantitative amount of alcohol. And you can see at the bottom, as we show these pictures as well, that are usually really reflect the drinking styles within the community where we're working, to try to even get to potential ounces of alcohol. We then, and the nice thing there is that because we do it monthly, we can get a sense of how the alcohol use changes through treatment and the year afterwards. We also use this biomarker, the phosphatidylethanol test, and you can see there you can do it as a finger stick, although we found it's a lot of blood for a finger stick. but it's dried blood spot, and it's a metabolite that stays in the system, and you can get sort of what's an approximation, again, a quantitative, semi-quantitative approximation of what's about the last 3 weeks of alcohol use. And we do this just at baseline for the most part, to try to minimize underreporting, and then we'll go from there. The other thing that we did, as we said, is we invested a fair amount of time and effort into trying to capture adherence. So these are some of our community workers, our women who live in the community, our neighbors, had already been trained as social support and community providers, and then we train them on our program. They carry a phone smartish phone that has this ComCare developed app that they can then scan and say that they were with the participant who shared their pill box with them, and that they witnessed or they didn't witness them taking the medication. And we're then able to approximate 5 days a week whether participants actually took their medication. So what are some of the things that we're finding? This is still a work in progress, although we have been fully enrolled. We ended up enrolling actually 350 individuals so that we have good, clean, complete data on out to at least 12 weeks on enough of them. So again, in AIM-1, what we're working on now is really trying to figure out this model of looking at this association. So our exposure currently is a latent class analysis, which I'll show you sort of how things fell out. And this incorporates 3 categories of the audit, 3 categories of intensity on timeline follow back from baseline presentation, and 3 categories for the PEth. Our primary outcome is time to culture conversion at 12 weeks. And then our modifier is treatment adherence by DOTS data with a time varying covariate. And so what have we found? Actually, this is a more limited number, but the numbers have stayed pretty static. So on 302 individuals, what you see is about a third fall into this low, really abstainer category. So these are individuals who have no indication of significant alcohol use on the PEth test. Their audit score is low or in the abstinent range, and their timeline follow back, they report no alcohol use in the prior 2 weeks. We then really used this approach to then discriminate between individuals who fall in a more moderate exposure group and a high exposure group, and you can see that on the right. I do want to point out again that individuals, at least in this community, who have tuberculosis also really do drink and drink a significant amount. And it's something just to think about again, whether we address it appropriately in many settings. But you can see that 70 of the 302 definitely fell into a category with high alcohol exposure. Sam Malatesta, who's a PhD candidate here in our biostatistics department, really has worked on our outcome of interest, which is this weekly sputum sample out to 12 weeks, where we use that to approximate if people have 2 weeks in a row of negative cultures or no growth. That was considered the week that they've converted their cultures. Not surprisingly, there's a fair amount of missingness, not even so much that we don't get the sample, but due to contamination or due to inability to produce. And so what we found is she developed and has published sort of the approach to how to impute those missing weeks. And it looks like about 20% of individuals still have not completely converted their cultures out to at 12 weeks. And that's really going to be the group that we're interested to understand if alcohol really is associated with this delayed sterilization. We're also going to look at 6-month outcomes, but those we don't expect to have enough events to necessarily be powered to capture at that point. So that's a reason that we thought that looking at this sterilization, which can be a proxy both for outcomes, but really also for relapse, is a good one to be looking at. The next piece that we've been cleaning and thinking about is this adherence summary. So Dr. Tara Boughton, who's an assistant professor in our division, has been really working with our team to look and clean and try to figure out how to organize this data. And so this is just looking at the 12-week adherence data. What we are seeing, which again is part of not surprising given that people had a DOTS worker, is that overall we do have high adherence in this cohort, which is good in the sense that we can sort of take that variable out of as not a major factor when looking at the association. But we've also have an opportunity here, and this is what Tara in part has been starting to explore, to really see whether short versus long gaps seem to have a difference, and is it associated with any other risk factors, and really just having a more granular look, at least in one cohort, around adherence use. Something else that we have an opportunity to do, and this is Sarah Weber, who's our project manager and is currently applying for her PhD, is really to look at alcohol consumption trajectories. So many times studies or research really looks just cross-sectionally at what people's patterns of alcohol use are when they are diagnosed with tuberculosis. But we believe, and I think there's reason to believe, that individuals may be drinking less at the time of their diagnosis for not feeling well, or just being sicker in general. And so the question is, what really happens to their alcohol use while they're in treatment and in the year afterwards? What you can see in this picture, males are on the left and females are on the right, and again, we're sort of continuing to clean this now, is that alcohol use, you can see it where it starts at the beginning, and that it actually stays, if anything, goes a little lower in our cohort during treatment. And this may be, again, being part of our research study, although we don't do any intervention or say that people should stop drinking. Certainly we acknowledge that asking people about their drinking every month may demotivate people to be drinking. But that you see in the year, but we also know that the clinic sisters who are providing the majority of the care to our participants do mention every month that while you're taking the TB medicines, you shouldn't be drinking because of the concerns for the liver. And so that may also suppress some behaviors, but that you definitely see in the year after people finish treatment that their drinking appears to go up and may approach again what their behaviors were like before they started. But what's interesting is, again, we're just starting to look, is when you start to apply and look at like alluvial plots, you see that those who are abstinent at the beginning do not correlate by color with those who are abstinent in the year afterwards. And sort of that is a predictor, does not seem accurate, and something that we need to think about if we do want to think about interventions or opportunities to address alcohol during TB treatment. So I'm not at this point going to go more into what was alcohol's direct effect on TB sterilization, because we're still finishing up those models. I will say that at least so far, we're not seeing a strong effect on presentation. And we have a number of reasons that we are starting to hypothesize and think about that. However, what we found unexpectedly was that our participants actually reported a lot of other substance use. So we had added another metric, the DUDIT, to our study because we thought we want to make sure we capture that small group of people who are using other drugs so that we can adjust it in our models. And we never really expected to see such high rates. So we, do both a self-report. The DUDIT is similar to the audit, but for other drugs of abuse or misuse. And we also do a urine drug screen for 6 drugs. And this is Dr. Bronwyn Myers, who was at the South African Medical Research Council. She recently moved to Curtin University in Australia. And this is a paper that we have near, hopefully, acceptance now. And what we found, like we said, was that actually half of our participants reported or had evidence of cannabis, methamphetamine, or methaqualone, or in other settings, they're known as quaaludes or Mandrax use. And that really was a bit of a shock to us. So we, so who are these participants? What we found is that those who are smoking drugs are more often male, they're younger, they are more underweight. So we know people with TB overall are underweight, and they report higher rates of having been incarcerated. What we find is overwhelmingly individuals are, it's polysubstance use. So there's a small group that are just smoking cannabis, but that the majority otherwise are using multiple drugs. And this again reflects in part using the meth to get high and then using the Mandrax or the cannabis or potentially alcohol to sort of chill or sort of come off of that high. And that what we found actually overall in our cohort of individuals who are getting treated for TB is that actually a very small number, only about 10 to 15%, use no substances. That this is actually a population that is using one or the other, even though it's not necessarily something that's fully addressed during their clinical care or really addressed at all. So the other interesting thing that we found was, at least in the clinical setting, smoking these drugs is associated with higher disease burden and by proxy potential higher infectiousness. So what we found is that individuals who smoked these illicit drugs compared to those who didn't in our cohort had a shorter time to positivity and were twofold more likely to be smear positive. We did not see an association with cavitation. There's very high rates of cavitation in our cohort, and the biggest predictor of that is actually previous TB episodes. But in these adjusted models, the smoke substances actually persisted as an important factor. So really what we found unexpectedly is not only that individuals with TB had a much higher rate of illicit drug use than what is at least estimated in the community in Worcester, which is more in the 7% range. This was half of our participants, but that they also look like they're coming in with higher disease burden and potentially a higher infectiousness state. And so this led us to our second major study, which I'm going to discuss today, which is the transmission of tuberculosis among illicit drug use linkages, or total. This is also in Worcester, and I'm sorry, I'm realizing I'm going a little slow, so I will try to speed up now. So this really was a pivot to stop looking at just outcomes, but really start to think about transmission. And really, I think many of us have been thinking about this already for a few years, but even more. And I think obviously we were also all influenced by COVID, I think, in thinking about transmission in the last few years. So I think we remain in this state of trying to understand where is the majority of transmission occurring that leads to secondary TB cases. How much are missed individuals important in maintaining TB incidence? What's the importance of subclinical TB and transmission? What proportion of TB spread is due to super spreading or clustered events? So how much is the dispersion factor? How low is the dispersion factor when it comes to TB? And what would be the impact of interventions if you could find a key population for TB transmission? If you then addressed that subpopulation, how might that impact on the greater population burden of TB? And then how do we continue to use our genomic methods to really define transmission? So what are some super spreading key populations and locations? So I think when we think about super spreading events, you think about needing prolonged contact, settings with poor ventilation, a highly infectious individual, vulnerable contacts, crowding, a high number of contacts, and potentially being a disease that's infectious even when someone is not symptomatic. And for TB, these are some key populations that definitely have been discussed in the literature: people with HIV, incarcerated populations, hospital or clinical settings, transportation. There's some question around schools, shelters, churches or places of worship, bars or shebeens, and people who use illicit drugs. So for this study, we're focusing on those persons who use illicit drugs. In 2016, Stop TB came out saying that, again, people who use drugs, and in their group, it was people who inject or smoke, just people in the category in general, are considered potentially a key population for TB. And that's in part because of work that's really shown that in low TB burden settings, outbreaks have been associated at higher rates among people who use drugs. In those settings, you've also seen that TB reflects more recent transmission when you look at the strain sequencing. There's also that people who are using drugs often have symptoms that overlap with TB symptoms, so may have delays in recognizing that they're ill and actually getting into and engaging in care. And another interesting factor is that more often people who are using drugs are young men. And we know from other TB research that young men, when looked in households, if they're the index case, there seems to be more secondary cases, that there may be some physiology or, again, delays in engagement in care, that young men may just be more infectious and therefore an important part of the transmission chain to really engage and get into care early. So what are we doing in our total study? So the first thing is that we just want to start to establish whether there's a higher burden of TB infection and disease among people who use illicit drugs, particularly smoke illicit drugs, in a high TB burden setting. So it's been somewhat investigated in lower TB burden settings, but not as much where there's a lot of TB around. So we're using a method called respondent-driven sampling, where we start with seeds, and then the main characteristic is that people then are given 2 coupons, and they need to bring 2 peers that they know that also use drugs, and bring them to our research site. And then they recruit and they recruit. So it's a peer-dependent recruitment, and then we do adjustments afterwards to adjust for the fact that this is dependent recruitment and not individuals who are unrelated. And so when they come, we're assessing TB exposure, risk of disease progression using some of the biomarkers that are established to be associated with risk of progression and more recent infection, and disease burden. So what we're getting is 2 induced sputum samples, one on the day that they first come, and then at a second visit, usually around 2 to 3 weeks later, and doing expert smear and culture to assess for disease. We're recruiting 750 individuals, again, all who smoke meth or mandrax, is what we're focusing on in this study. Then among those that we find disease, we're doing whole genome sequencing of their strains and getting more detailed social network information, social locations and such, to estimate the proportion of cases that are from recent transmission and start to try to locate where are higher risk areas within this community. And then with Robin Wood at Desmond Tutu Foundation, excuse me, we're using his RASC, which is a bioaerosol capture unit. And we're looking to see whether people who smoke drugs have TB disease with physiologic characteristics that are associated with more infectiousness. So we're looking at the bioaerosols of 50 individuals who have TB who smoke drugs and 50 individuals who have TB who don't smoke drugs. And we're also getting chest x-rays. And so when you do respondent-driven sampling, you need to start by doing formative work. This is Dr. Tara Carney, who is a senior specialist at a South African Medical Research Council and a behavioral psychologist as well. And she definitely is the leader on a lot of this stuff. And so we, in February 2020, met with the Community Advisory Board in Worcester, as well as did 8 focus group discussions around the advisory group topics you can see in the box on the side, trying to make sure that we located our community clinic in a good location, understanding if our incentives were appropriate, what would be good coupons, how do we message, and also assessing and confirming that the people who smoke illicit drugs in this community are socially linked and not going to be hard to reach through peer networks. We did these in isiXhosa and Afrikaans, and also stratified by gender. And then we actually did 2 additional isiXhosa focus groups in 2022, stratified by gender, when we were a bit concerned about recruitment from one of our communities. So again, this is the study schematic of how we do recruitment. We initially were starting with a few seeds. We, in AIM-1, get the sputum that I mentioned. We do TB symptom screening. We do blood draws for HIV testing, which we do a rapid and give results on the spot. Get the PAX gene tubes, and also we're doing COVID serologies. We do biobehavioral assessments and respondent-driven sampling interviews. We estimated we might find, of the 750, about 45 to 75 active cases of TB, defined again as culturable TB. And then enrolled as many of those as possible into the AIM-2 visit, where we do the social contact survey and get a second sample of the TB for potential sequencing. And then in AIM-3, as we mentioned. So what have we been doing? So we were delayed by a year because of COVID, but we did launch in April of 2021. And to date, we've enrolled over 540 individuals, and these are the enrollment trees. So again, many of these people probably know each other and have contact with each other, but this is just who recruited who. What you see in blue are individuals who report being born male versus red is born female. The yellow highlights are the number of individuals that we found culturable TB. So this was a slight bump the week that I pulled this, which is 2 weeks ago. But we are finding that 9% of these individuals who, again, were recruiting in the community and their only risk factor is using illicit drugs, we are finding culturable TB. We expected it to be high. This is even beyond. So I will say probably we will land again closer to where we've been for the last year and a half, which is around 7 to 8%. The 9% is a slight bump, but we've been pretty consistent. There are other individuals in light blue who have expert positive or trace, but their cultures were negative, so we're not including them in these counts. And what we're finding is, I'm sorry, this is much higher, like I said, than the community rates. So the South African Tuberculosis Vaccine Initiative, or SATV, in their Cordis study a few years ago, had done a survey of the walking well. They found and estimated about 2 to 2.5% TB cases that they were finding in the community. So this 7 to 8%, again, is very, very high rates. This is just a distribution. This is a map of Worcester and where people are coming from. So we don't give any boundaries to how far outside of Worcester people can come, but we're not finding recruitment from outside of town. But what we're finding is a pretty good distribution across our neighborhoods. And then what you see is Welatemba, which was historically the under apartheid, the Black African or Xhosa community, which has a lot more physical barriers, even though the distance is not all that different from coming into Worcester. Again, we placed the stars where our community clinic is, and this was really based on feedback from all of our groups about what was a good business area, gang neutral area to put our site. We were concerned about reaching them, but they've been pretty consistently 15 to 20% of our recruitment, which actually is about the same size as the proportion of the 150,000 individuals living in the greater Worcester area. So this is really looking at what's the difference between those who we are finding TB disease versus those who are not. And what you're finding is that those with TB disease are slightly older. They do report, we have very, very high rates of reporting some incarceration. So about 70% of individuals say they've spent, and again, this can just be like a few nights in prison, but I think it again reflects the criminalization of drug use in South Africa, as we see in much of the world, and it may be a real source of infection for TB. We've recently had a slight bump in those who are co-infected with TB and HIV. We're also finding a lot of new HIV diagnoses. We've diagnosed 34 individuals newly with HIV. And again, this is checking the charts that they've never been diagnosed, and they say they've never been diagnosed before. So that's another thing that we're reaching in this group that smoke drugs, not use other illicits, and very low rates of, actually not really much, if any, receptive anal sex that we've had reported in our HIV risk survey. And then these individuals are very highly connected. So those, on average, people say, we ask, how many people do you know who smoke drugs that you've seen in the last few months that you could recruit to the study? And on average, people report 20. And it's interesting that the number reported among people with TB disease is actually significantly higher. It's been pretty consistently 30. It's just low significance now. The other interesting thing that we're finding, or had an opportunity to look at, is that we're finding lower burden disease by looking in this, who we're recruiting in the community. So total participants on the left are those that we've diagnosed with TB through this community-based respondent-driven sampling approach, compared to those from the first study that I mentioned in Trust, who are passively being diagnosed. So this is coming to the clinic because you're not feeling well and getting diagnosed. So we're finding lower burden disease. This time to positivity is 12 days on average versus 7 days among those presenting to the clinic. The smear status flips, so those in the community now are 75% smear negative, compared to in the clinic it was only 25% smear negative. The other interesting thing is that we're finding what probably by some characters is considered subclinical TB. So 60% of our participants in total are reporting no symptoms when we add the WHO symptom screen. Not surprisingly, pretty much 100% of those from Trust had symptoms, and that's because we continue to diagnose TB. We only really get screened if they have symptoms, if they come to clinic. But I think it's a real opportunity at showing that we are able to get into the population and getting to them earlier in their disease progression. Although it raises some interesting questions about what will then motivate them to link to care. And we are both encouraging and helping them link to care, but we will follow up and see if they actually engaged in treatment or not. We've just started getting some sequencing samples back, but much to, I guess, our excitement is that it does look like we're finding some clustered outbreaks. So even with this approach, we are probably successfully getting dense sampling. The one in the middle, the orange dots, are definitely, their SNP differences are between 0 and 2. The other groups are a little bit more lenient. The SNP differences are as much as 9 and 1, but we're seeing overrepresentation of lineage 2 rather than lineage 4 for this region, and we're excited to continue to get more of these sequences back. So like I said, we're about 75% enrolled. We expect to finish enrolling in this study later in this year, and the bioaerosol work continues as well. So I think takeaways are that from this second study is that it does look like there's a higher prevalence of TB disease among people who smoke illicit drugs in this high burden setting. We can reach and engage this population, which many people have wondered, especially we do fingerprints because we need to for the RDS, so we don't enroll people more than once. We ask everyone to do a urine screen as they walk in. This has not deterred people. The feedback are very eager to be engaged in the work and the study. This is a potential to show again that we can also find subclinical disease in this group and potentially find these transmission links and sites. And really there's opportunities for interventions with potential population level benefit. So at Brevels Kloof Hospital, which is the TB hospital in Worcester, a photographer came and got approval from the patients to do this photos, which are now up on the walls when you walk through the hospital. And it jumped out to me that when this woman was interviewed, she said, "I'm happy here. We have a full day and there are lots of talks on substance abuse in families." And that, we've also gotten this from our focus group work, that talking about and addressing substance use when we're thinking about TB is also something that's very motivating to individuals who are living with TB and within these communities. And I think continuing to figure out the dynamics of whether this is a key population for TB would really potentially open a lot of things up, even in high burden settings. And as always, this work is really many, many people. So I want to put that out as a thank you. And so thank you for listening to me today.
Thank you very much, Karen. Unfortunately, because we're on a webinar, you can't hear the applause, but you can certainly see it. So it was a really amazing talk and fascinating work. So I'm just going to ask the audience, as they're cheering and clapping, please do add some questions into the Q&A section. But while people are thinking about it, I will just kind of start with a couple. Some of those, the numbers that you described there are really astonishing. You give the proportion of people that use drugs in your population compared to what you'd expect the prevalence in the community, and then again, the rates of TB or the prevalence of TB in those groups are again astonishing. And I wondered to what extent you knew whether this was something that you would expect in urban settings across South Africa, or do you think there are sort of elements which are unique to the Worcester setting?
Yeah, thank you. So I'm eager to repeat this in other settings. Anecdotally, most times when I've given this talk, someone or a version of this talk or shown this data, someone has come to me and said, I think this is happening in the community where we're working, whether it's some of the townships around Cape Town, whether it's Durban, whether it's other rural areas. So I think we really do need to explore this more and really understand what's the dynamics. Maybe the drugs are a little bit different, maybe the drug use patterns are, but I think that this is a population, again, whether it's because of the interfacing with the penal system or other vulnerabilities and cofactors, that really is carrying a higher burden. And what jumped out the other day is that there was a recent publication from a setting in Vietnam where individuals were recruited for injection drug use to see rates of TB with and without HIV. And again, they found very high rates, 2-3%. I think they even did symptom screens. But one of the things that jumped out in that survey as an independent risk factor for TB disease was smoking meth. And this is Vietnam. And again, it's a group that is injecting drugs. So I think, in TB, I think we've just gotten a little bit locked in, not that in high burden settings, everyone's at risk because there's just so much TB. And we certainly treat HIV as a particular key population and children under 5, but I think we need to think creatively, or we need to continue to dig into, not just saying there's just so much TB, it's just a blanket approach. We need to continue to tease out, because I think services too and opportunity to engage groups I think that there is more of a super spreader heterogeneous dynamic here that we might have a more efficient effect if we could start to continue to bring out. So maybe it's not just smoke drug use, but I think continuing to find these key populations is going to be important.
Great, fantastic. And the other thing, so you've, I know you're analysing this, and it's really interesting to see the whole genome sequencing data you've got, and also the kind of clustering diagrams. If you were to think, or to speculate about why these rates are so high in this group, do you think it's a question of just like high levels of transmission amongst people that are using drugs together and co-localizing, or do you think there are other kind of factors at play?
Yeah, I mean, I think that's what we're really interested to keep digging into. I think that it's layered. I think we all believe, I think that the force of infection in penal systems is so high, and given the very high rates of having been incarcerated, that probably sets people up. I mean, this is, again, just for the backdrop, Worcester is a community where they've done surveys, and they find that 80% of individuals have evidence of TB infection by the time they finish adolescence. This is where the adolescent study was. And so this is individuals who already probably have baseline infection and then get multiple opportunities for repeated infections, whether, like we said, it's through the shared behaviors and just the opportunity for infection, through using drugs together in these sort of closed settings to avoid being seen, as well as I think it's just a social dynamic of how the drugs are used. But that's something we're digging into more. It's being in the incarcerated setting and opportunity. But I think we may also be getting into, another colleague brought up the phrase that I think more of us are using around hot nodes. So, we may be starting to reveal and get into parts of the network where individuals are just so socially connected and have so much opportunity for repeated exposures and being part of these clusters. If you think about it, the individuals who get recruited by RDS, if you are more socially connected, you have more likelihood over time of someone in your network to come to you with a coupon and say, do you want to come and be a part of this? So we may be biasing ourselves. And again, we're doing things then afterwards to adjust for it, but we're biasing ourselves towards people who are the most socially connected. And yet they may be those who are also the most at risk of getting TB and progressing to disease because of repeated exposure. We've talked with actually recently, like Tom Scriva, to start to look at whether there may be other indications, since we have the RNA transcripts, that maybe there are ways that the meth or drugs may also modify the host response. But I think, again, the goal of this has been really just to establish what was the disease burden and start to understand the links and dynamics. But I also would be interested to know from others also just this opportunity to think about when people who smoke drugs come to the clinic, they have this much higher burden disease, and yet when we find them in the community, we're finding them in many times this subclinical phase. And that just feels like there's an opportunity for intervention there as well.
Great. Okay, let's go to some of the questions from the audience. So Joel Freeland says, congratulations on your work, and wonders whether there are differences of note between male and female drinkers, and if there's an association of HIV with drinking.
Great. Thanks, Jerry, for joining. It's nice to see your name. So I think we are definitely seeing a gender difference. It's something that we're cleaning and digging into now. Certainly men still drink more, but we do have an opportunity to look at women who also have very high rates of heavy drinking. I don't think we've looked into the HIV sexual exchange question as much among drinkers. We definitely are asking those questions and thinking about it in those who are using illicit drugs, that we do believe some of the HIV is driven through transactional sex in this group. But I think there would be potentially an opportunity there. I think we do have information on where people drink, and much of the drinking is done in the home more than in bars in this community, but that is data that we still need to clean. Great.
And just then moving on to Wazi Khan's question, again says, thank you, really interesting talk. Was there a difference in adherence to treatment between those that use drink alcohol and those that use illicit drugs?
That's a great question. It's something that we're working on now. Tara has started to look at this question around the gaps and some of the patterns there. Hopefully we'll have some of that soon. I don't have those answers quite yet.
And then just, I guess, as a follow-on, what about toxicity between those groups as well? Do drinkers have more toxicity? Are they harder to manage during treatment?
So we didn't see that. We found, I think as many have found, that our participants were actually quite stoic about their symptoms. And it took a bit to encourage them to report symptoms and side effects, even if they were experiencing them. We have a medical student now, Christy Tselios, who's working with Maha Farhad on cleaning that part of our data and really trying to get at, there were very few participants, if any, there was at least one or two who had to stop because of liver toxicity from medications, but this was not a major effect, but we're working on cleaning and understanding the relationship, particularly of alcohol, to any of those side effects in this cohort, at least.
So did that surprise you? Were you expecting more liver toxicity?
Yeah, we were, and that's why we kept going back and having to even train our nurses about different ways to really encourage people to talk about. So, I mean, again, I think no one really looks for side effects. We did not do blood draws at every visit. It was really a symptom-based screen, and then we would only do blood draw if someone reported symptoms. And people don't expect, I mean, people I think are willing to tolerate a lot of, it's hard to know if it's that we just missed toxicity, but we did not see a huge amounts from at least what we've initially looked and cleaned, but we're still cleaning some of that data.
Okay. Great. And last question, I think, before we have to sign off from the webinar, from Mark Lippman. Again, great presentation, thanks. Do you feel that you can develop interventions which can start to change behavior and improve long-term generational outcomes, or is this too aspirational?
Great. I don't want to think it's too aspirational. So I think we've been doing, again, Tara Carney and earlier Bronwyn Myers developed, we've been doing some qualitative work to really look and think about what would be readiness for people who drink. We don't think necessarily in these settings that TB is enough of a major life event to say, okay, I'm going to change in response to it. But we do think that there is a real opportunity to engage people even during TB care in ways that will potentially have impacts on their alcohol use. So I would like to think, again, we started to try to understand readiness for interventions through some of our work. I think what we're really excited about and we hope to do is put together almost like an implementation project around how to find TB among people who use illicit drugs. What we're finding is that our participants say that they really like coming to our study site. And that's one reason why we continue to get so much recruitment so fast, that they feel, compared to going to clinic where they feel looked down upon and stigmatized, they can come talk about their drug use, get these different tests and leave and feel positive afterwards. 40% report wanting a referral to substance use intervention. And again, we don't require it at all, but that's higher than we expected. And so we're really trying to think about how to take RDS and adapt it to a model about how to have a community-based testing, screening, referral in high burden settings. So I like that aspiration. Again, it's very much weighing on it's driven by my colleagues who really know how to engage on some of these things. But I think I think we're overlooking this opportunity if we don't do it.
Thanks, Karen. I think that's probably all we've got time for, but just want to thank you for a really fantastic and exciting webinar, just that kind of mixed methods approach that you're taking, amazing epidemiology, quality research, great scientific work as well in all sorts of disciplines. Really looking forward to hearing your results from these two projects as they come through, and maybe you'll be able to come back and speak to us in person maybe next time. So good luck with the rest of your project. Thank you very much for taking time out of your day to speak to us, and thank you for the audience for joining us and for your fantastic questions. And this will be up on our YouTube channel quite soon.
Great, thank you again for this opportunity.